All right, good evening. It's evening here for me, but good evening, good morning, everyone. I am going to be lecturing today on our hematological disorders and oncologic emergencies that we might potentially see in the critical care environment. So before we begin, I'm going to start by talking about coagulation and fibrinolysis in a healthy patient. We all know that hemostasis is the ability of the body to control bleeding and clotting. In a healthy person whose body is in hemostasis, they will bleed if there's an injury, but their body is able to control that by clotting and preventing excessive bleeding. There are four major actions involved in achieving homeostasis. There's local vasoconstriction, which helps to constrict the blood vessels, which helps to decrease the blood flow to the area, which helps to decrease blood loss. There's platelet aggregation and formation of a platelet plug to seal off that hole from the blood vessel to prevent blood from escaping. There's formation of a fibrin mesh that strengthens the plug. And then once the repair to the vessel is complete, then there is clot dissolution, where your body actually breaks down the clot that is formed, so then blood flow can continue through that area unimpeded by that clot that had been formed. So there are 13 different clotting factors that work together to help achieve homeostasis. But the common pathway, they all lead to prothrombin and fibrinogen being converted to their active forms, which is what creates the clot. So you can see here, right, you've got thrombin being activated through a lot of these different, these are all factors. So this is factor 12, factor 11. They're different clotting factors, which we can actually give if a patient is lacking in one. So once thrombin arrives at the injury, the platelets become activated. They change shape, become sticky, and that's how they start to stick to each other and to create this clot. And as they are activated, they release a bunch of factors that help in clot formation. But what's really interesting, so factor 10 becomes active through this process and converts prothrombin to thrombin. And thrombin converts fibrinogen to fibrin. And the fibrin creates strands around the clot, creating like a net that traps the platelets, red blood cells, and white blood cells, and that's what secures the clot in place. And then the clot, excuse me, will continue to attract some platelets to continue. They'll be sticky and continue to form that clot to help healing, to help promote healing in your patient. Now, so you can see here, initially, instantly, you can have vasoconstriction happening in the vessel, right? So if you vasoconstrict and tighten down that vessel, less blood is going to come through, and therefore less blood can leak out and leave the vasculature. Then you have your fibrin, your platelets starting to create the clot here. And you can see that platelets are changing shape. Oh, I went out of order. That's why it didn't make sense. Vasoconstriction. Then you've got platelets starting to form here. They're changing shape and become sticky, which allows more platelets to stack on here. Then your fibrin starts to create this net here. And then the entire clot forms here. But you can see how this whole clot could easily impede blood flow. So once this tissue has healed, you want the blood flow to be able to flow freely through this vessel. So as the tissue begins to heal itself, um, then their fibrinolysis begins. So your body actually produces TPA, which I know you've heard of. We talked about it with stroke and with STEMI, but your body actually is the one that first produced that TPA to break down the clot. So once there is healing, then this clot actually gets dissolved and breaks down so blood flow can go smoothly through this blood vessel again. So right? Normal conditions, healthy patient, the body has feedback systems. So, prostacyclin 1 is one of the prostaglandins that's released that counteracts the effect of one of your tissue factors. So that way the clots doesn't continue to form to the point of being too large, blocking the vessel, and cutting off blood flow past that area. So there are feedback mechanisms in place that allow the clot to form, allow healing to take place, but then once the healing is done, your body then breaks down the clot and you don't just keep clotting over and over again. That becomes a problem we'll talk about later. So once, like I said, once healing has occurred, uh, fibrinolysis begins. So that's the dissolution and remodeling of the clot to maintain blood flow. So as soon as the fibrin clot is formed, thus fibrinolysis begins. So plasminogen gets trapped in the clot and binds to the fibrin, and then the actual injured cell wall, the epithelial wall, releases that TPA, your tissue type plasminogen activator. So the actual injured site is what releases that TPA, and that's what starts to break down the clot. And then the plasminogen is floating in your body. It attaches to the clot. The endothelial lining produces the TPA. It takes plasminogen, turns it into plasmin, and the plasmin slowly begins to digest the fibrin, so it breaks down the clot. Now, one important thing to note is when fibrin is broken down, you have what are called fibrin degradation products. Those are released into your body and they act as anticoagulants. So it's actually something we can measure is not just fibrin, but the degradation products, the things that are created when that fibrin is broken down. It's an important process to kind of have a grasp on as we move forward. So, one of the first or main diseases of coagulopathy is called disseminated intravascular coagulation. It's pretty uncommon, and most of the time we don't know what causes it, which is really fun. But it can be a complication of other factors, and things like pregnancy puts you at higher risk. Actually, sepsis is our number one contributor. 20% of patients who go into DIC, it's as a result of sepsis. But the majority of the cases, we honestly don't even know what causes it. But it is a disorder of both bleeding and clotting at the same time. And as we kind of go through a basic pathway, you'll start to understand how that's possible. But it's bleeding and clotting together. So if it's left untreated, it quickly progresses to multiple organ failure and death. Yay. And then they die, right? That's our complication for a lot of these diseases. So, interesting note, gram-negative organisms, for whatever reason, sepsis caused by gram-negative organisms is more likely to lead to DIC than any other sepsis. Don't really know why, but just a neat fact there. But no matter what causes it, or if we don't know what causes it, there's damage to the endothelium, so the endothelial lining of the vessels, that results in activation of the coagulation process. So there's tissue factor and that extrinsic pathway from like the second slide gets activated. So all this thrombin formation begins, and the body is consuming all of your coagulation factors. All those clotting factors we talked about, all those clotting factors you saw in that pathway of like in a healthy person, they start getting used up. And then the stores are depleted. So your body is clotting. It's using all of these clotting factors. It's clotting in places where it doesn't need to be clotting. And so that now all the platelets are being used, all the fibrins being used. You've got all of these clots going on. But it's using up all of the platelets and things that your body needs to clot. So then you start bleeding because you don't have homeostasis. All of that clotting factor, all of that platelets, everything that you need, your body needs to create clots where it may need to clot to prevent bleeding, it no longer can because your body's clotting in inappropriate places. So thrombi continue to form along the damaged epithelial wall, and you end up with occlusion of the vessels. So you're clotting, right? We know, think about like heart attack can be caused by vessel occlusion, right? Or stroke or PE. These are vessel occlusions that lead to these big problems. Well, now we've got clots and thrombi forming everywhere in your body. They can pop up anywhere. So they can pop up in your heart and cause ischemia to the heart muscle. They can pop up in your brain, cause ischemia in your brain. They can pop up in your lungs. They can pop up everywhere. DVTs, in your extremities. You can lose circulation to extremities. So then there's further tissue damage, which leads to more clotting, which leads to more bleeding. So because all these clots are being created, then the fibrinolytic process begins, all that fibrinolysis. So now you're breaking down the clots. There's TPA being produced, and the clots are breaking down. You have these fibrin degradation products, which act as anticoagulants in and of themselves. So those are being produced, and you don't have enough of the clotting factors because your body has used them all up. So now you're bleeding excessively. So the textbook says death is imminent if this destructive cycle is not interrupted. So you've got the cycle of clotting inappropriately, which leads to more tissue damage, which leads to more clotting. But the clotting factors are all used up, and your body is starting to break down those clots, which is normally a healthy process. But all of that TPA and those anticoagulants that are being released into your blood stream now are causing excessive bleeding. So it's this kind of vicious cycle of clotting and bleeding at the same time. So you can kind of see here That's kind of just like a visual of what we talked about. So there can be massive tissue destruction or sepsis, some sort of endothelial injury, any of those things, which releases your tissue factor. Right now, you've got all these widespread microvascular thrombosis happening, which can lead to vascular occlusion, which leads to your ischemic tissue damage. Right? If you have enough tissues that are damaged, you're going to have MODS. Right? A couple dozen, at least 2 organ systems with enough damage that their organs start failing. Now you've got MODS. At the same time, you have activation of the plasmin, which leads to your fibrinolysis, these fibrin split products, and that leads to bleeding. And you've got consumption of all of your clotting factor and platelets because all of the clots that are forming, which also leads to bleeding. So you've got clotting and tissue damage in conjunction with bleeding, all working against everything, leading to serious complications. So, one of the biggest things we can do to promote favorable outcomes for patients is early recognition. We want to pick up on the signs and symptoms early on before we get too far, into the vicious cycle that is DIC. So, what are you looking for? Well, you're looking for, right, signs of bleeding and signs of clotting, because you're going to have both of those things going on. So, you can have thrombi in your peripheral capillaries, which would lead to cyanosis and eventually gangrene of those areas. You can have ischemia in your tissues, in your organs. Um, so you can see, um, right, like and then you also are going to have bleeding signs. So for the integumentary system, are your thrombi signs here, but peripheral cyanosis and gangrene. Where on the other side, you could have bleeding from your gums, venipunctures and old surgical sites, nosebleeds, right? Anywhere that you've got an opening. So if you've got an IV site, now it's bleeding around your IV site, the one that you started, 2 days ago on your patient, or around their central line. Um, they got a surgical wound that just all of a sudden starts bleeding profusely, things like that. Right? Cardiopulmonary, you can have bleeding, so you can have a patient coughing up blood, but you can also have chest pain because they're starting to have cardiac ischemia. You can have dysrhythmias. They can have a STEMI, an acute MI. You have PE, respiratory failure, right? Kidneys, you're bleeding, you can pee out all the blood, or you can have clotting, you can have a complete lack of urine production and acute kidney injury. GI, you can have a massive GI bleed, but then if your bowel and your gut is dying, you can have bowel infarct, constipation, and or diarrhea. And then, of course, right, we can have either type of stroke. The patient can bleed into their brain, or they can have an infarct in their brain, or they can have both. So you want to look for those signs and symptoms of bleeding and the signs of symptoms of um, tissue damage due to the thrombi. The lab tests you're looking for increased coagulant activity, increased fibrinolytic activity, impaired regulatory function, and end organ failure. So you can look at your PT, and that's one of your clotting times, that's going to be elevated. Your platelets are typically going to be under 50,000, but it could be just a 50% drop from baseline. So if their baseline was 200,000 and now they're at 100,000, they've, even though they're not below that 50,000, they've dropped at least 50%. And so that's a significant drop, and that would be indicative of DIC. Their PTT is going to be elevated, right? D dimer, we talked about this lab before, that it is an indicator of clotting, or the patient is going to be clotting quite a bit. So they are going to have an elevated D dimer. Now, they're fibrin degradation products. I said we could measure those, right? Those are the products that are created when the fibrin that was on the clot is broken down, and it acts as anticoagulant. Well, we can measure those, and so you're going to have a lot of those. You're going to have an excess of fibrin degradation products, but your fibrinogen is going to be low because it's all going to be used up. So your platelets and your fibrinogen are going to be low because we're using all of that, and your clotting times and your D-dimer and your fibrin degradation products will all be elevated. So what do we do about DIC? So, right, your treatment, you're going to do symptom management and you're going to do treatment based on what their signs and symptoms are and what their labs show. So, if they're having chest pain, you're going to treat their chest pain. If they're having, stroke symptoms, you're going to treat that. You're going to treat what you see. Because MODS is a very real complication. MODS can easily happen because you could have clots, and or bleeding in multiple organ systems all at the same time. So we want to prevent end organ ischemia and damage by supporting blood pressure and circulating volume. So that is going to come down to IV fluids and inotropes. So we're going to have the heart pumping stronger and harder. We're going to increase that blood pressure. We're going to make sure they've got plenty of IV fluids, make sure that they've got enough circulating volume. And then we're going to look if they're having, if we're seeing overt signs of bleeding, they're having massive GI bleed or, significant hematuria, or we have any of those signs of overt bleeding, they're going to get a PRBC transfusion. If they have severe platelet depletion, so if we look at their platelet levels on labs and those are significantly depleted, then we're going to give a platelet transfusion. If their fibrinogen levels drop below 100 milligrams per deciliter, then we're going to administer cryoprecipitate. And there's actually a new treatment, what's called antithrombin 3, that's recently been approved and may be helpful in arresting the cycle of DIC. But we want to figure out, right, so if we can identify the cause, we're going to do that. Like I said, 20% come from sepsis, so if it's a sepsis patient, we're going to continue to treat them as we would. I believe you talked about that last week with G. But right, antibiotics, fluids, and then supporting their vital functions. Right, prevent hemodynamic support, blood and blood components depending on what this particular patient needs. Interestingly enough, heparin is one of the treatments, right? You think, hey, professor, the patient's bleeding. Why are we going to give them heparin? But what's interesting in DIC is, heparin more or less helps to stop that inappropriate clotting. So we've got all these clots forming everywhere. And if we stop those inappropriate clots from forming, that's also going to stop the breakdown of those clots, which leads to more anticoagulation. So giving some anticoagulation to stop that initial clot formation is going to prevent those clots from being broken down and creating more of your body's own natural anticoagulant. So it helps that process and it helps the platelets and the clotting factors to be available to clot in places that they need to be able to clot. It used to be standard across the board. It's all we ever did was heparin for DIC. It's becoming less common, and there's research on both sides of the fence. So it's not just standard treatment anymore, but it still is used. And I talked about the antithrombin 3. Of course, we're going to do bleeding precautions, right? We want to ensure that we're not going to do anything to aggravate bleeding, that we are not starting 10 IVs on this patient, that we're not doing invasive procedures, if at all avoidable, and initiate all of our bleeding precautions so that way we don't aggravate the problem. Of course, we're going to watch for our complications like hypovolemic shock, ischemia in either their periphery, in their limbs, or in any of their central organs, and of course, MODS. And as always, you're right, going to provide comfort and emotional support because this is super scary. And there's not a ton. We're going to do everything we can, but we can't always recover from this. So, right, we're supporting the vital functions, bleeding precautions, comfort, and emotional support. So, we're watching vitals very closely, all their hemodynamic parameters. We're watching intake and output. We're watching those lab values we talked about, their clotting times, their fibrin degradation products, your fibrinogen, platelets, all of those things. And then, things like if they need labs, we're going to draw it off their central line or off an existing IV because we don't want to poke them unnecessarily, right? All those bleeding precautions that are super important. So, next, thrombocytopenia, which basic, if your platelets are under 140,000, you have thrombocytopenia. It's a fancy word meaning low platelets. That's what it is. It usually occurs following some sort of viral infection, after certain medications, after blood transfusions. Alcoholics tend to have low platelets, after pregnancy, if they've got splenomegaly, cancer patients. These are all patients who are going to have potentially low platelet counts. So, right, it can be caused if you aren't creating enough platelets, if you are using up too many platelets, like in DIC, if your spleen is sequestering the platelets that are being made, or platelet dilution. Excuse me. The most common form of thrombocytopenia seen in the critical care setting is going to be called immune thrombocytopenic purpura, which is ITP, which we're going to talk about the most in the following slides. So in ITP, lymphocytes produce antibodies that begin to destroy the existing platelets, and we don't know what causes it. But we don't have enough platelets, so your normal coagulation pathways are disrupted, and you end up bleeding. This can lead to life-threatening GI bleeds or intracerebral bleeding, but it doesn't tend to result in visceral hemorrhage and or large hematomas. So, again, your signs and symptoms, you're going to have petechial hemorrhaging of your lower extremities, ecchymosis, gingival bleeding, spontaneous nosebleeds. Tends to have these ITP tends to have a gradual onset, and you're going to diagnose basically based on their history and their physical exam. So this is very important to note. Also, very interesting. You're going to have petechial hemorrhaging, which are those small red spots primarily on your legs, and you can also see them on the oral mucosa. That's indicative of a platelet disorder. So think platelets, think P, platelets, petechial hemorrhaging. Large hematomas are more indicative of coagulation disorders, not low platelets. So low platelets, petechial hemorrhaging, large hematomas are coagulation disorders. But unusual bleeding is a hallmark of ITP. So you're on your CBC, you're going to see severely diminished platelets, oftentimes even below 30,000. But your RBCs, WBCs, hemoglobin, and your coagulation studies and bleeding times are all going to be normal. You just simply don't have enough platelets to get the job done. So they may have signs and symptoms of a stroke, neurologically speaking. They may have nausea, vomiting, seizures, decreased level of consciousness, right? We talked about hematuria from the renal system. They can have all the signs of GI bleeding, hematemesis, melena, hematochezia, so bright red blood top or bottom, coffee grounds or dark stools. In women, this can lead to really heavy menses if they're in their reproductive ages, post-pubescent, premenopausal, retinal hemorrhaging, And like I said, that on your labs, you're going to see this decreased platelet levels. Now, for the most part, ITP, we don't know what causes it, and it reverses itself spontaneously. We don't always need medical treatment if it's mild. Um, for these mild cases, you can give oral corticosteroids, but if you're having life-threatening hemorrhaging, obviously we're going to need to intervene. We don't let our patients bleed out. So we can give IV immunoglobulin, high-dose methylprednisolone are both um, typically effective. But if steroid therapy fails, then we consider removing the spleen. We also can give platelets, right? You don't have enough platelets. Let's give you some more platelets. But we have to figure out what's going on to hopefully stop those platelets from just getting destroyed instantly. And then, of course, we're going to watch for any signs and symptoms of major bleeding or severe blood loss and providing emotional support as always. So there is another type of thrombocytopenia that we are going to talk about. This one is specifically seen typically in the hospitals, and it's only seen in patients who have received heparin. So this is only a portion of our patients, but it's called heparin-induced thrombocytopenia. I'm sure some of you remember way back in your memories to second semester, we gave a lot of heparin injections on the floors at Scripps. And one of the things on your MAR that it said was do not administer if platelets are less than 100,000. Right? This is one of the things we check for. This is what we're looking for. This right here that we're going to talk about, this is why you had to go and check your platelet levels on any patient that you were giving heparin to. So, there's two types of heparin-induced thrombocytopenia. The most common form is non-immune mediated HIT, type 1, and the second form is type 2 or immune mediated, which is less common, but it's more serious. So your immune mediated HIT, it's a response to the administration of heparin therapy. So you're going to have severe thrombocytopenia. It is identified by a platelet count of less than 50,000, or again, that 50% decrease from the baseline platelet count. So that's why it's always important to have a baseline platelet count before you start heparin so that you can monitor that and make sure that it doesn't drop more than 50%. You're first going to see heparin-induced thrombocytopenia occur between 5 and 14 days after initiation of therapy. Now, that's the first time in their life they get heparin. With re-exposure, that drop can occur within hours. So the very first time they get heparin, it's not till between 5 and 14 days after they receive that heparin before you might see this. But the second or third time they get heparin, if this is not recognized, that drop can occur within hours. So, the thrombocytopenia that occurs for this type of thrombocytopenia is a result of heparin antibody complexes that are formed. So, the heparin and antibodies create a complex, and that releases a substance known as platelet factor 4. Platelet factor 4 attracts heparin molecules and forms these immunogenic complexes that adhere to the platelets and endothelial surfaces. So then activation of the platelets stimulates that release of the thrombin and the formation of platelet clumps. So patients with the immune-mediated HIT are at a greater risk for clotting than for bleeding. So there is formation of these fibrin and platelet-rich thrombi, and that it's much more common, and you're going to see more signs related to ischemia than to bleeding. Um, so if you look here, right, you've got your heparin and platelets, and here, so this number 1, you have activated platelets releasing proteins, including that platelet factor 4, and your heparin binds, your heparin, here's the blue squiggle, binds with this platelet factor 4 that was released into the bloodstream. Okay? Then um, your body produces an immunoglobulin IgG antibody that reacts with the heparin PF4 complex. So you've got these heparin-induced thrombocytopenia antibodies that interact with this complex that has formed with your PF4 and your heparin. So this reaction forms your heparin platelet factor 4 IgG immune complex. You create this big old complex here. Um, then these complexes will bind receptor, to this receptor and create these big complexes that then will activate the clotting cascade. And then it attracts more platelets to the area and leads to these clots here. So just know your heparin binds with this protein, which binds with the antibodies, which then binds and attracts platelets to the area and creates these massive clots. So, like we talked about, heparin-induced thrombocytopenia, you're going to have much more of those signs and symptoms of clotting than of bleeding. So you're going to have that chest pain, diaphoresis, change in blood pressure, dysrhythmias. They're going to have, if they're having clots in the arterial side, pain, pallor, pulse, paresthesia, paralysis, your P's, your 5 P's, just like in peripheral artery disease. And then if there's clots in the venous system, right? Think about like DVT, pain and tenderness at the site, one-sided leg swelling, warmth, erythema, pain on your dorsiflexion, right? All those things that you would look at for like a DVT, because that's basically what it is. You're having clotting happening in the veins. You can have dyspnea, rales, chest pain, chest wall tenderness, back pain, shoulder pain, shortness of breath, hemoptysis, wheezing, decreased urine output because you're going to have damage to the kidneys from the clotting, abdominal pain, vomiting, abnormal bowel sounds. Then you can also have, right, signs of stroke, basically confusion, headache, impaired speech, that one-sided weakness, facial droop, all of that. And you're going to see platelets with less than 50,000% or a drop of 30 to 50% from the baseline. So this is why rapid recognition is key. So that's why we want to always be monitoring our patients who are getting heparin. So your key indicator is going to be that platelet count. And so if they've had heparin and they have that 50% drop from baseline, then that's going to be strongly suggestive of heparin-induced thrombocytopenia. For high-risk patients, we want to be monitoring their plates every 2 to 3 days, starting at day 4 until day 14 on him. So we can be watching, right? I said starting day 5 typically is when you're going to see the significant drop. So if all of a sudden we do see a sudden drop, we're going to immediately stop the heparin therapy. And the patient's going to be tested for those heparin antibodies that were produced, we talked about on that previous slide. We can use direct thrombin inhibitors to treat heparin-induced thrombocytopenia, as they will bind to the thrombin molecule and inhibit its action. So argatroban is the more common, and then there's another one called loperamide. Those are the two that have been approved for use in the U.S. So nursing management, one of the first things that we want to talk about is recognition and early recognition. So we want to decrease the incidence of heparin exposure, watch for complications, and provide comfort and emotional support, and educate the patient and family. These patients, this is a true allergy. This is a true adverse effect. If patients develop this, they can never have heparin ever again. And so we want them to be very much aware of that. It's a good idea for them to have a medical alert bracelet. But then you need to think about things like, no heparin flushes in their central lines, or if they have any sort of indwelling port or PICC line or anything like that. Any of their hemodynamic pressure monitoring systems, if they're putting heparin, that we're using in that. No heparin coated catheters, no heparin flushes, all those little things need to be taken care of. Obviously, we're going to discontinue the heparin therapy that they were getting. We're going to be watching them because they remain high risk for those clots for up to a few weeks after they've stopped the heparin therapy. So we're going to be educating the patient's family again as to what to be looking for if they're not going to be remaining in the hospital, what signs and symptoms to be aware of, all those different signs of clotting, all the different signs that something's going wrong, and when to seek help and who to seek help from. We also are monitoring for those things while they're in our care. And then we want to make sure that they are never exposed to heparin again, because it can be worse second time around. So medical alert bracelet is a good idea, and making sure that the heparin allergy is listed in their chart. So our next disorder we're going to talk about here is called tumor lysis syndrome. So this obviously means you have to have a tumor that is being lysed. So this is a complication that we see, and it's actually a complication of our cancer treatment, not of the cancer itself. So tumor lysis syndrome refers to a variety of disturbances that are seen with the treatment of cancer. This is actually it can be a lethal complication from treatment, and it occurs when a large number of neoplastic cells are rapidly killed, resulting in the release of large amounts of potassium, phosphate, and uric acid into the blood circulation. Your most common types of cancer we see this in are patients with lymphoma, leukemia, or if they have multiple metastatic conditions where it metastasized to multiple locations. So we're treating the cancer patient with typically chemotherapy, and it's killing the tumor cells, yay. But too much of a good thing, I guess, can be problematic. So it's most often associated with the use of chemo, but it also can be biologic agents, radiation, and it can actually occur spontaneously for some of our cancer patients. We can also see if they have elevated WBC counts, large tumors, or if there's multiple organs involved, they tend to be more likely to develop this. So, because all of these cells are rapidly killed, right? If you remember, potassium is your largest intracellular electrolyte. So there's all this potassium inside your cell. If we kill all these cells, they all lyse and they expel a lot of potassium into your bloodstream. which we all know how bad that is, right? We've talked about potassium over and over again. But you can have skeletal muscle manifestations as well as cardiac manifestations. Most deadly are your ventricular dysrhythmias, of course. So as we talked about with our potassium previously, we want to do IV insulin and glucose. Has to be IV rapidly. They also get sodium bicarb. Inhaled beta agonists like albuterol actually will help decrease your serum potassium level. Potassium binding resins, that's like your Kxalate. And then calcium gluconate actually is in that IV cocktail. It's another medication we can give IV to rapidly help. And then we can also, if all else fails, we can do dialysis to remove the potassium. Of course, right, we know that's going to take a lot longer, so we want to start with this insulin glucose IV, bicarb IV, and calcium gluconate IV, and then we'll move forward from there. So when you have the destruction of all these cells, you're also going to have an increased phosphorus. Your phosphate levels are going to increase. And this may be compounded if they have any sort of renal dysfunction, which can be super common with chemotherapy. It can compound this problem. So they're going to see muscle cramps, potentially even tetany with that, dysrhythmias, and that can also lead to seizures. So we can give the patients phosphate binders, but a lot of times they are going to need dialysis as well. So your phosphate and calcium have an inverse relationship. So as your phosphate increases, your calcium is going to decrease. So with this sudden influx of phosphate, you're going to see a sudden decrease of calcium because these calcium phosphate complexes are formed. So when there's also this phosphate in your bloodstream, it binds with the calcium. And so now all of a sudden you have very low calcium levels, which will also lead to muscle cramps, including tetany, dysrhythmias, seizures, and it can cause significant acute kidney injury. So, right, low, just like any other low electrolyte, we can give some of that electrolyte. So, low calcium, we can give calcium. But your hyperphosphatemia and hypocalcemia can both lead to cardiac arrest and death. So, big problem there. And then you also have increased amounts of uric acid from the cell lysis, which leads to levels of purine. Basically, when the cells are lysed, you have purine nucleic acids that are in the circulation that are metabolized into uric acid. So that can lead to uric acid nephropathy, which leads to renal failure. So our best bet here is lots of hydration. And we can actually give some medications called xanthine oxidase inhibitors, and if needed, dialysis. So you can kind of see here visually what we just talked about, right? So you got all your malignant cells, they're lysed, it releases all of these components here, your uric acid, potassium, and phosphorus. So your hyperuricemia and phosphatemia are going to lead to your decreased calcium. So you've got crystal deposits, which are going to lead to kidney problems. You have all of these aggravating factors. Volume depletion, hypertension, you're going to end up with acute kidney injury, which means you're not going to be able to process out any of that potassium or phosphorus. And you're going to have hypocalcemia and have cardiac arrest. You're also going to have fluid overload and respiratory failure. lots of complications can come with this. So, um, right, we often think of our chemo patients as being very emaciated. They've lost a lot of weight. They're very frail looking. So that's one of the big differences here is you're going to see weight gain, and that's a lot from the fluid shifts, the fluid retention, because of the decreased kidney function. So that kind of is a key indicator to look for because that's different than typical than other things. Where if you think look at the other signs and symptoms, your lethargy, cramping, nausea, vomiting, diarrhea, weakness, numbness, those can all be side effects of chemotherapy. And that's something that patients may be experiencing anyways. So they may not think anything of it. But weight gain tends to be the opposite of what happens. So that's kind of a hallmark to look for. Um, right, lab findings. So this is why a lot of cancer patients get routine labs because they are looking, this is one of the things they're looking for. How are their electrolytes doing? Because if all of a sudden their electrolytes are out of whack, then this is probably what's going on. You're going to see positive Chov-sec and Trousseau sign because of the hypocalcemia. They're going to have hyperactive um, deep tendon reflexes if they have hyperkalemia and hypocalcemia. They can see EKG changes, right, are really high potassium. We're going to have those peaked T waves. We'll have widened QRS complexes, and we may see different dysrhythmias depending on their level of electrolyte. So our aims here, we're looking to maintain hydration. We want to treat the metabolic imbalances and prevent life-threatening complications. So these cells all died. They put all of this extra phosphorus and uric acid and potassium into the body. So now we need to figure out and treat those complications that all of those electrolytes in the blood are going to cause and keep the patient alive until we can process out all of those electrolytes. Hopefully, then if we've killed off all the tumor cells, then we're not going to have this problem again. But if there are more tumors, then this could be a recurring issue. So, but once we've helped to balance the electrolytes and get their body back to functioning, make sure the kidneys are functioning and all of that, then hopefully their body should be able to maintain homeostasis. So we're watching electrolytes and ABGs. We're having them restrict their intake of potassium and phosphorus potentially. When we're talking about that hyperuricemia, we don't want formation of uric acid crystals, and so we want to keep them very, very well hydrated so that they can flush all that uric acid out. We can also give sodium bicarb, which helps to increase the pH of the urine, which helps to prevent the formation of uric acid and allows the uric acid to be like dissolve in fluid versus having those crystals form. And we can actually also give allopurinol. It's a gout medication to help prevent those crystals forming. Right? We can give all of the treatments we talked about for the potassium. So we kind of talked about, so we want to make sure they're well hydrated, treat the imbalances, and treat any life-threatening complications. Obviously, they're having dysrhythmias, having the ventricular dysrhythmias. Those are going to be the biggest ones that we're going to be monitoring for and treating. Right? If they go into VFib or VTAC, we're going to be treating that as it occurs. So we want to monitor fluid and electrolyte status. We want to watch their I's and O's, make sure intake and output are matching. We don't have a significant decrease in our output, which we could also see by weight gain. We're watching for those complications. We're educating the patient and family what to be looking out for, what signs and symptoms, what things are strange, who to contact, where to contact them. while the patients are in the hospital, things like seizure precautions should be in place. You saw seizures were a side effect of a lot of those electrolyte disturbances. Um, if they're having major copious amounts of nausea, vomiting, NG tube may be in place, especially if they're not protecting their airway well. Dietary adjustments and restrictions, and lots of fluids. Lots and lots of fluids are going to be important. Right, these patients they're going to need IV fluids. They may need a catheter for strict INO monitoring. So then we have one more, I guess we'll call it illness, ailment, um, dysfunction, as we're talking about coagulation. Um, and this one is 100% iatrogenically caused, meaning we cause it 100% of the time. But it's simply anemia of critical illness. So it's a hospital-acquired disorder that's seen in critically ill patients, and it's the result of inflammation, iron deficiency, trauma, surgery, GI bleeding, and iatrogenic blood loss from diagnostic testing. So basically, we make our patients anemic because they're critically ill. So their body already, any trauma, surgery, GI bleeding, inflammation can lead to anemia. But then we are so desperate to know what's going on that we're drawing their blood incessantly. Think about our DKA patient we talked about 2 weeks ago. Think about how we are drawing potassium every 2 hours, and we're drawing a complete metabolic panel every 4, and we're finger stick testing them. But when their glucose is too high and the blood glucose machine isn't giving us a reading, then we're drawing their blood for glucose checks every single hour. So we're drawing blood off our patients, those poor patients, you know, potentially more than 24 times just in one day. And if they've got a central line, hopefully we're not poking them that many times, you're pulling off 10 mLs of waste every time. That's 240 mLs just of waste, not including um, the actual blood samples we're taking. So one of the big things we want to do is minimize blood loss. So that's why those really awesome blood conservation contraptions on your central lines are going to be so important, because if you can pull back that 10 mLs of blood, take your blood sample, and give that patient back those 10 mLs, in your mind it gets only 10 mLs. But with how frequently these patients are getting their blood drawn, their body is already in a state of stress, a state of illness. It's already combating all of these things going on. And so to tax it further by taking away perfectly good blood and red blood cells that is unnecessary, it's just going to prolong the healing process. These patients, they need their RBCs, they need oxygen, they need the oxygen carrying capacity. So we wanted things like those, um, they're called closed loop vascular devices, where we can pull back that blood and return it to the patient. Sometimes we can actually use pediatric tubes, depending on how severe this is for our patients. These pediatric tubes for adults can be good. Um, blood salvage devices, rather, those are what they're called. Um, we want to control hypertension. We want to manage their oxygen delivery and consumption. So all the things we talked about, especially when we're in that pulmonary unit, things that are going to increase oxygen consumption, fever, shivering, nursing interventions, all of those things that increase oxygen consumption. If we can minimize those things, allow our patients rest between procedures, all of those things. We want to make sure that we're stimulating their own production of red blood cells. things like epogen, right, erythropoietin, stimulating medications. Vitamin B12 is important. We're going to give fluids and inotropic agents to make sure that we can have adequate cardiac output and blood pressure. Potentially, they may need vasodilators to vasodilate the vessels to decrease afterload so that you have increased cardiac output. Uh, and then encouraging safer transfusions and alternative agents. We are moving away from um, significant transfusions. We're using them more sparingly just because there are so many complications with them, because it's so hard to come by blood. Um, there's so many risks, all of those things. Um, so obviously we will use them when needed. Um, but if there are other things we can do to stimulate the patient's own red blood cell production, we're going to try that first. Um, things like autologous transfusions of the patient, it's a lot harder, but if they know they're going to be ill, or patients like we have devices we can use. They've got a chest tube and they're putting out copious amounts of blood from the chest tube, where we can actually, it goes in line with the chest tube, and it has certain um, ingredients. It's not the word I'm looking for, but there's certain components in this contraption that the blood that's draining out of their chest cavity then goes into this more or less blood bag, and it gets treated, and then we just give it right back to the patient. They get their own blood that they're more or less bleeding out, and it gets treated and put right back into their body. So it allows them to get those RBCs that they lost without the risks of a traditional blood transfusion. Um, and there's also new things they're coming out with, like recombinant DNA technology that helps their body to make more of their own red blood cells, plasma expanders. Um, so we're making blood transfusions as safe as possible, and then also trying to find alternatives that we can use. So the biggest way to handle this, right, we just want to minimize that blood loss, conserve their blood, manage, reduce that oxygen consumption as much as possible, make sure that they are able to make their own red blood cells, and then we can do a transfusion if needed. So these last slides here are just